So imagine getting a quick cosmetic injection on your lunch break.
Right.
And the clinic tells you, like, you're completely good to go. But biologically, your body is actually reacting to a microscopic trauma that requires, well, a full week of strict healing.
Exactly. It's a huge disconnect.
Yeah. So today, we're taking the casual modern concept of the lunchtime cosmetic procedure, and we are moving it completely south.
We really are. We are looking at a space where this highly aggressive commercial marketing is just directly colliding with the complex, the really unforgiving biology of the human pelvic floor.
That is exactly the collision we are unpacking in today's deep dive. We're looking at the booming world of infant wellness procedures. Specifically, we're zooming in on the heavily advertised G-shot.
Right, which you see everywhere now.
You really do. And, the glossy clinic brochures we've gathered make this sound as simple, painless, and routine as getting your lips plumped before a dinner date.
Yeah, they really push that quick fix angle.
But when you look at the actual medical reality, like the post-operative protocols, the strict mechanics of human tissue repair, and the official guidelines from major medical institutions, that whole quick errand illusion just totally shatters.
Because, the tissues we are talking about are not like the skin on your forehead or your jawline.
Right.
You are dealing with highly vascular, deeply interconnected mucosal membranes. So when you alter that environment, you are triggering a massive cascade of biological responses.
So our mission today is to cut through all that marketing noise for you. Whether you are prepping for a medical decision, recovering from one right now, or you just want to understand the wild mechanics of your own biology.
Yeah.
We're exploring what happens actually after the needle comes out.
The real aftercare.
Exactly. We're breaking down the intense realities of G-shot aftercare, the absolute non-negotiable rules of something called pelvic rest, the surprising science behind tampon and intercourse bans, and what the broader medical community actually thinks about all of this.
It's a lot to cover.
It is. And we've pulled from a really wide stack of sources for this. We have plastic surgery marketing materials, official hospital post-operative care guides, and the clinical committee opinions from the American College of Obstetricians and Gynecologists.
Which is a perfect cross-section, really. You have the aesthetic industry's pitch on one side and the traditional surgical recovery reality on the exact opposite side.
Let's start right with that pitch, actually. The G-shot. So in the clinical literature, this is referred to as anterior vaginal wall augmentation.
Yes.
And according to the clinic sources, the procedure is mechanically pretty straightforward. A provider uses a specialized speculum to inject a dermal filler, so usually like a medical-grade collagen or a hyaluronic acid, directly into the anterior or the front wall of the vaginal canal.
Right where the G-spot is supposedly located.
Exactly. And the goal is to temporarily plump that tissue, creating a physical raised bump. They aim for something about the size of a quarter in width and maybe 1/4 of an inch in height.
So a very specific structural change.
Yeah. It sounds exactly like getting facial or lip filler, but placed in a highly sensitive, functional area.
Well, the underlying logic being sold here is purely mechanical. By creating that physical bulk, the extra projection into a relatively tight space, the idea is that you increase friction.
Right.
You increase targeted sensitivity during penetrative sexual intercourse. You are literally building a localized speed bump to increase physical contact.
Okay, so I understand the friction theory. That makes sense. But this is where the sources start to violently disagree with each other, and where the biology gets, well, really confusing.
Oh, absolutely.
Because some of these aesthetic clinics claim the actual injection takes 8 seconds, 8 seconds, and they state that afterward, you can just leave a normal tampon in for 4 hours to stop any scant bleeding, take it out, and then you are totally cleared to resume normal sexual activity that exact same day.
Which is a bold claim.
Right. But then other specialized providers in our stack strongly advise waiting 5 to 7 full days before having sex or even using a tampon.
Yeah, that's a massive difference.
So how can the exact same procedure have a 4-hour recovery on one website and a 7-day recovery on another?
To understand that massive discrepancy, we really have to look at how hyaluronic acid filler actually works on a microscopic level and the specific environment it's being injected into.
Okay.
So the vaginal mucosa is incredibly vascular. It has a rich, dense blood supply and is heavily concentrated with nerve endings. Now, the hyaluronic acid used in these procedures isn't just a watery liquid. It is what we call cross-linked.
Wait, what does cross-linked actually mean in this context?
It means the individual sugar molecules in the acid are chemically bound together, kind of like a microscopic three-dimensional net.
Oh, interesting.
Yeah, and this prevents the body from instantly breaking it down, so it allows it to hold its shape. But it also means the filler acts like a dense, highly absorbent sponge.
Ah.
So when you introduce a needle and inject that dense sponge into tight, delicate mucosal tissue, it immediately starts absorbing local water and expanding. You are stretching tissue that isn't naturally meant to hold that kind of localized, rigid volume.
So you are creating intense internal pressure.
Exactly.
So if a patient follows that 4-hour timeline from the one clinic and they have penetrative sex the exact same day, what is physically happening to that area?
Well, you are subjecting fresh, punctured, swollen, and actively expanding tissue to intense friction and impact.
Oh, yikes.
Yeah. The 5 to 7 day wait time advised by the more cautious clinics is based on biological necessity. The body just needs time for that filler material to integrate with the surrounding cells and actually settle.
That makes sense.
If you apply immediate blunt force, you risk physically displacing the filler. You could push the gel right out of the intended zone.
Oh, wow. So you could literally push the bump to the completely wrong spot.
Yes, you could. And furthermore, anytime you puncture the mucosa with a needle, you create an open pathway for bacteria.
Right, of course.
And the vaginal canal has its own very complex microbiome. So if you introduce friction before that puncture wound has completely sealed shut, you are massaging bacteria directly into a deep tissue pocket.
Ugh, that sounds awful.
It is. Waiting a week allows the body to form a microscopic seal over the injection site, which drastically reduces the risk of a deep secondary infection.
That makes the walk-in, walk-out marketing seem incredibly reckless, honestly. You are creating a biological wound, even if it's small.
A wound is a wound.
Right. And if a simple 8-second injection requires a week of careful healing, it really makes me wonder about the hospital recovery guides we looked at for major surgeries in this area.
Oh, it's a totally different ballgame.
Because those guides introduce a concept called pelvic rest. And looking at the rules for pelvic rest, it seems like the body's reaction to trauma in the pelvic region is incredibly severe.
It's a critical shift in perspective, for sure. Moving from a minor cosmetic injection to a structural surgery like, say, a vaginoplasty to tighten the muscle walls, or a labiaplasty to alter external tissue, or a major repair for a prolapsed pelvic organ, it requires a totally different paradigm of healing.
Yeah.
Pelvic rest isn't a suggestion to just, take it easy. It is a comprehensive, rigid, physiological protocol that typically lasts for a strict 6 to 8 weeks.
I want to dig into these specific rules because they are fascinating to me.
They really are.
So the cornerstone of pelvic rest across all the hospital sources we read is an absolute unconditional ban on penetrative intercourse and the use of tampons.
Non-negotiable.
Yeah, non-negotiable. And I'm looking at this tampon ban, and honestly, I'm confused. If you've just had surgery and you are actively bleeding as you heal, isn't a highly absorbent tampon exactly what you'd want to use to manage that?
You would think so.
Right. Why are pads the strict rule?
It's a very logical question, but it comes down to 2 major mechanical risks. First, consider what a tampon is actually made of. It's dry, highly absorbent cotton fibers.
Okay.
When you insert that into a vaginal canal that has fresh internal surgical incisions, those dry fibers can physically adhere to the wet, healing edges of the wound.
Oh, no. So when you pull it out...
You can physically rip the delicate new stitches right out of the tissue.
Oh, wow. That is horrifying.
It is. You are essentially tearing the wound back open.
Okay, yeah, no tampons.
Right. And second, a tampon is designed to hold on to fluids. In a post-surgical environment, introducing a foreign object that soaks up blood and holds it at body temperature directly against an incision.
Oh, that sounds like a bacterial nightmare.
Exactly. It creates a perfect warm reservoir for bacterial overgrowth. You use pads entirely outside the body because the internal canal must remain completely unobstructed.
Okay.
And medical teams need the patient to be able to visually monitor the volume and color of any bleeding to catch hemorrhages early.
That paints a very vivid, if slightly horrifying, picture. It makes total sense now. But the physical limitations go way beyond just avoiding internal objects.
Oh, definitely.
The sources explicitly state that during pelvic rest, you cannot lift anything heavier than a gallon of milk.
Which is really light.
That's roughly 10 pounds.
Yeah.
For 6 straight weeks, no picking up a toddler, no dragging a heavy laundry basket, no lifting groceries. Why does carrying a grocery bag affect a surgical site inside your pelvis?
Well, To understand that, you have to imagine your core as a cylinder
Okay, the cylinder.
and think of holding a water balloon that's just been patched at the very bottom with a really delicate piece of tape.
Got it. Visualizing the water balloon.
The pelvic floor is the hammock of muscles at the bottom of that cylinder, supporting all your internal organs, your bladder, your uterus, your rectum.
Right.
When you lift a heavy object, or perform a deep squat, or even just cough heavily, you naturally brace your core.
Yeah, you tense up.
You create a massive spike in intra-abdominal pressure. The diaphragm pushes down, your abdominal muscles tighten, and all that internal pressure shoots straight downward to the weakest point.
Which is the pelvic floor.
Yeah.
The patched bottom of the balloon.
Exactly. If you have fresh, dissolving internal stitches holding those muscles together after, say, a prolapse repair or a vaginoplasty, that sheer downward force can literally burst the sutures open.
Oh my God.
The internal repair can completely fail just from lifting a heavy box.
That is wild. You just don't realize how interconnected the core is until you see the mechanics of how it breaks.
It's all connected.
And managing that healing process sounds like a full-time job. I mean, the daily hygiene routines outlined in the sources are exhausting. Patients are taking warm sitz baths multiple times a day.
Yes.
They are completely banned from using toilet paper to wipe. They have to use a peri bottle.
Yeah, a peri bottle allows you to gently squirt a stream of warm water to cleanse the area. Because again, we go back to friction.
Like friction.
Wiping dry paper across fresh mucosal sutures will tear them. You rinse with the bottle and then carefully pat dry.
The sources also talk about icing the area, but strictly in 10-minute intervals. And you are banned from swimming or sitting in a hot tub for a month?
The hot tub ban is entirely about waterborne bacteria entering those deep surgical sites.
That makes sense.
And the icing limits are because the tissue is already traumatized. Leaving ice on too long restricts local blood flow, which starves the tissue of the oxygen and nutrients it desperately needs to rebuild cells.
Okay, so there is one specific requirement for vaginoplasty patients that really stood out to me. This is where the vaginal canal itself is surgically tightened.
Right.
They have to do something called vaginal dilation. Why is that required?
Because the human body is incredibly efficient at healing, but sometimes it's to its own detriment.
What do you mean?
Post-vaginoplasty, the body recognizes a massive trauma to the canal. Its natural defense mechanism is to bridge the gaps by laying down thick scar tissue. If the canal is left alone, the body will literally try to heal it shut by gluing the walls together. Or it will heal so narrowly that the canal loses all functional elasticity.
Wait, it just tries to close the tube completely.
Exactly. It just wants to close the wound. So patients are required to use medical dilators, which are smooth, progressively sized cylinders.
Right.
They must insert them for about 15 minutes, multiple times a day. You are actively, physically stretching the fresh scar tissue, forcing the body to heal in an open, functional, and elastic position.
Wow. Hearing the intense mechanical reality of how the pelvic floor heals how severely it reacts to trauma and scar tissue, it really makes you look at that 8-second G-shot injection differently.
It puts it in a whole new perspective.
It really does. If the physical recovery from even minor tissue trauma is this delicate, it begs the question, is the broader medical establishment actually on board with injecting dermal fillers down there just for a temporary friction boost?
This is where we find a very hard line drawn in the source material. We looked at the official committee opinions from the American College of Obstetricians and Gynecologists, ACOG.
ACOG.
They're essentially the governing authority for women's health standards in the U.S. And ACOG explicitly and strongly warns against cosmetic vaginal procedures like G-spot amplification.
Yeah, they do not mince words at all. The texts show ACOG stating these procedures are not medically indicated and that they completely lack documented safety and effectiveness.
They're very clear on that.
But I want to challenge that warning for a second. It's just based on what we learned earlier.
Okay.
If the hyaluronic acid filler just naturally dissolves and is absorbed by the body in 4 to 8 months, what are the actual long-term permanent risks that ACOG is so worried about? I mean, it's temporary, right?
Well, the filler itself is temporary, but the biological consequences of the injection might not be. ACOG outlines several specific, severe mechanical risks. We discussed infection, which can travel deep into the pelvic cavity.
Right.
But the major concern they highlight is the risk of adhesions and severe scarring.
What exactly is an adhesion in this context?
Think of adhesions like internal spider webs of rigid, glue-like scar tissue.
Okay.
Every single time you puncture that specific mucosal tissue with a needle to inject filler, your body's immune system responds by creating collagen to heal the microtrauma.
Which is normal.
Yes, but if you are going back every 6 months for a top-up injection to maintain the bump, you are repeatedly traumatizing the same exact spot.
Oh, I see.
Over time, the body lays down a thick matrix of rigid scar tissue that mistakenly glues the independent layers of the vaginal wall together, or it even glues the wall to underlying structures like the urethra.
So you completely ruin the natural elasticity of the tissue. You're trying to increase pleasure, but you're actually building a dead zone of rigid scar tissue.
Exactly, and that leads directly to the most concerning risk ACOG lists:
Oh.
altered sensation and dyspareunia.
Dyspareunia.
It's the clinical term for long-term or even permanent pain during sexual intercourse.
Oh, wow.
The anterior vaginal wall is a highly concentrated web of sensitive nerve endings. If a needle nicks a nerve, or if those rigid scar tissue adhesions trap and squeeze a nerve, the tissue loses its ability to stretch normally.
That makes sense.
When that trapped nerve is pulled during intercourse, what was meant to be a cosmetic enhancement procedure results in chronic, agonizing pain.
That is a terrifying mechanism.
Yeah.
So that is the danger of adding physical bulk to the area with a dermal filler.
Yeah.
But, our sources also brought up another highly advertised injectable called the O-shot.
Yeah, the O-shot.
And it seems like the clinical approach to the O-shot is fundamentally different. It doesn't use hyaluronic acid at all. It uses platelet-rich plasma, or PRP.
Correct.
So how does PRP work mechanically compared to the G-shot?
It is a completely different philosophy of treatment. As we covered, the G-shot uses a foreign gel to create a structural speed bump.
Right, the bulk.
The O-shot doesn't add physical bulk. Instead, a provider draws the patient's own blood and spins it down in a centrifuge. This isolates the platelets, which are the blood cells responsible for clotting and healing, along with concentrated growth factors. They then inject that golden plasma back into the clitoral and vaginal areas.
So if you aren't building a physical bump for friction, what is the plasma actually trying to do inside the tissue?
It is essentially a biological trick.
A trick.
Yeah. Platelets are the body's emergency responders. By injecting a massive concentration of them into a specific area, you're tricking the local tissue into believing there has been a major injury.
Oh, I see.
This triggers a massive localized healing cascade. The goal of PRP is cellular regeneration. It forces the body to grow new, healthy blood vessels, increases natural tissue hydration, and theoretically encourages the regeneration and repair of nerve endings.
You're trying to upgrade the biological hardware from the inside out rather than just changing the shape of the room.
Exactly. It's a completely different approach. Now, to maintain total impartiality based on our sources, it is vital to note that ACOG remains highly skeptical of all elective, undocumented cosmetic procedures.
Right, including the O-shot.
Including the O-shot. They cite a lack of large-scale, long-term clinical trials. But within the actual aesthetic and regenerative medicine fields, the O-shot is viewed as a functional therapy, aiming for nerve health, while the G-shot is viewed purely as a structural spatial modification.
Seeing the mechanics behind both really changes how you read those clinic brochures.
It really does.
And for you listening, this is exactly the kind of knowledge that changes how you interact with the medical world. By understanding the vascular nature of mucosal tissue, or how a tampon interacts with fresh incisions, or, why a gallon of milk can compromise your pelvic floor through intra-abdominal pressure.
You elevate yourself past the glossy marketing.
Exactly. Yeah. Understanding the massive gap between a breezy lunchtime sales pitch and the stark biological reality of how human tissue heals is how you take your power back. It ensures you can make truly informed decisions about your own body, asking the right questions instead of just accepting the brochure.
Knowledge is the ultimate protection when navigating elective medicine. And to that end, there is one final underlying point buried deep in the anatomical research within our sources that I think completely reframes this entire debate about injecting the G-spot.
Oh, I love a twist. What did the anatomical sources say?
Well, the entire premise of the G-shot relies on finding the G-spot and inflating it. But modern clinical texts reveal that the G-spot isn't a distinct, isolated anatomical button that you can just find on a map.
Wait, really?
Yeah. Scientists and anatomists increasingly refer to the area as the clitoretrovaginal complex, or the CUV complex.
The CUV complex. That sounds much more intricate than a single spot.
It is incredibly intricate. It is a highly variable, dynamic network where the internal roots, or the crura of the clitoris, the sensitive tissue surrounding the urethra, and the anterior vaginal wall all physically interact.
Wow.
It is a web, not a button. And because it is a web, its sensitivity varies wildly from person to person based on their unique internal geometry.
That makes so much sense.
Some people feel immense euphoric pleasure from pressure in that zone. Others feel absolutely nothing. And both physiological realities are entirely normal.
That fundamentally changes the conversation. I mean, if the very anatomy of pleasure is still debated by scientists, and if we know it functions as an interconnected, deeply individualized web,
It raises a profound question. Are we trying to use a blunt, one-size-fits-all physical gel filler to force a mechanical fix onto an experience that is deeply individualized, anatomically unique to every single person, and largely psychological?
are we just trying to put a simple cosmetic Band-Aid over a beautifully complex biological system? That is absolutely something to chew on. Think about the intricate web of the CUV complex next time an ad promises a quick, 8-second fix for human anatomy. We hope this deep dive gave you the tools to see past the marketing. Thanks for exploring the science with us, and we'll catch you next time.